Kashayar, welcome. The mic is yours, my friend.
Okay, first I want to thank Simi here for making the threshold to record because Zachariah couldn't be here and he really wanted to uh, at least watch the recording. So this is a reflection session on the session on December 19th presented by Zachariah on an RLR session. I highly recommend those who haven't watched it go and watch it again. I watch it again today just for preparation of this session, and it is just mind-blowing, both the case and the discussion. So, a brief summarization of the case. This was a story of a 32-year-old male who presented with recurrent GI bleeding and chronic pancytopenia. During workup, the interesting findings was both massive splenomegaly and massive hepatomegaly, which developed a case for us. And further development was a bone marrow in 2016, which showed no dysplasia, and hypercellular bone marrow with diminished iron stores. And finally, the diagnosis was revealed by a biopsy of the liver, which showed congenital liver fibrosis. So this is just a general summarization of the case. And today I have a case with diagnosis in the same realm. But
Hmm.
before we go on to that, I want to ask Robbie to kind of reflect on the case after the session because I remember he was post call on the session and just want to hear what you think.
Your memory is perfect, my friend. Yeah, thankfully I haven't been post-call since then, and I spent a lot of time reflecting on the journey that we took in that case. The first is to sort of emphasize the overlap between pancytopenia and GI bleeding. And I think at first glance that was the problem we were introduced into. Uh, and at first glance, it seemed to me in that post-call delirium that was an unusual problem. And in some sense, it was unusual because the patient lacked the other third feature that makes what is otherwise a common chain of three things. And those three things we see all the time is cirrhosis, pancytopenia, and GI bleeding as a result of esophageal varices. And so, thing that was glaringly absent in that patient's case was the cirrhosis part of the that trifecta of cirrhosis, splenomegaly causing pancytopenia, and GI bleed. And so, it seemed um, unrecognizable. And it's interesting. You can take that one of two ways. You can either say, since there is cirrhosis, there probably isn't the unifying feature of portal hypertension that combines to cause pancytopenia through splenomegaly and GI bleed through esophageal varices. Same simple mechanism. So you could say, okay, what there is no cirrhosis, but maybe there's portal hypertension through a non-cirrhotic mechanism, or you could start to get very rare and very esoteric and think about all the other ways that pancytopenia can infiltrate directly the GI tract. So that was an interesting reflection, and it prompted a mini academy session, which is recorded on YouTube, about how the platelet count is such an important marker for anyone with GI bleed, and that when you have thrombocytopenia plus GI bleed, you should really think portal hypertension no matter what. And so, if you take that leap of faith and say, I'm going to think about thrombocytopenia plus GI bleed um, as portal hypertension, then it becomes a simple way of trying to confirm that. And the best way of confirming portal hypertension is to see the consequences of the high portal pressures, especially when you, well, I should say the best way to measure, to confirm portal hypertension is an invasive catheter-based measurement. Um, but I'd say the simplest way is to measure or to observe the pressures at the point where they're the highest. So if you ask yourself in patients with portal hypertension, where I'm most likely to develop the highest pressures? Maybe we can just actually think about that as a group. So, Mohammed, I see you switched your very warm beanie for a more aerated hat today. I'm glad it's a little bit warmer than the last time I saw you. I'm curious, what do you think about that question? Where do you think the patients with portal hypertension have the highest pressure?
Robbie, do you mean the site?
Yes, yeah, I mean the site, exactly.
Um, if it was cirrhosis uh, causing portal hypertension, I think um, were the portal vein distally meeting
Yes.
and entering the liver.
Yeah, if you ask yourself a concept to sort of translate in patients with venous hypertension, where is the pressure highest? And the pressure is highest at the point furthest upstream. Because if you ask yourself, blood is flowing to the liver in patients with portal hypertension. And if blood is flowing to the liver, the pressure is highest the moment that vein is formed. And the pressure continues to decrease the closer and closer and closer you get to the liver, allowing blood to flow from that initial point all the way downstream. So this is why, if you're looking for the best test, short of actually directly measuring the portal pressure, it's to do an endoscopy to see the site of origin of all the venules with the EGD. This is why when patients have venous stasis, their lower legs are the most prominent part of their edema, right? Is because the pressure is the highest there and then flows retrograde. And so that's the best way to confirm portal hypertension is to do a catheter measurement or to look at the dilation of the veins where they are most under pressure in the lumen of the GI tract. And then after that, after you kind of diagnose that, see varices or whatnot, it's a localization exercise. The localization exercise is very, very interesting and full of fun aspects. The way it's divided is if you try to localize it pre-hepatic or before the liver, intrahepatic or post-hepatic. And in the case that Zachariah had, there was a very powerful localization clue in that the liver was enlarged. And when you have hepatomegaly, that effectively excludes a pre-hepatic cause through the simple idea that if the liver is involved, the disease must be either in the liver or after the liver. So it could be that the liver is infiltrated by something horrible and that's why it's big, or it could be that the liver is just congested because the problem actually is in the hepatic vein, causing Budd-Chiari as an example. So in that case, the liver was massively enlarged. So now you know you're not dealing with any form of pre-hepatic portal hypertension, and that unless your hepatic vein Dopplers are elevated or your BNP is elevated, the answer will come from a liver biopsy. The only way you can avoid a liver biopsy in a situation where the liver is involved and there's no congestion is when you have an indirect proxy of what could be happening in the liver serologically. And that's the leap of faith we took in Zachariah's case, hoping that we could prove that there was features of schistosomiasis or features of a myeloproliferative neoplasm that you could diagnose. Both of them can affect the liver in some way. And ultimately, those were ambiguous, so a liver biopsy was needed. And just to re-emphasize it, if you have a pure case of pre-hepatic portal hypertension, the liver is not involved. But in fact, actually, the liver is affected and often shrunken, primarily because the portal circulation provides two-thirds of the nutrition to the liver. And so deprived of that, because of sluggish flow, there really can be consequences on the liver. So the simple reflection is reflex thrombocytopenia plus GI bleed equals portal hypertension. What's the diagnostic gold standard? Is invasive catheter-based measurements. What is a realistic proxy? Realistic proxy is to do an EGD with varices. What's a common alternative proxy? Is to do an ultrasound with Doppler and see that there are flow changes in the portal vein. Um, those are kind of the tools that we use. And in terms of localization, first thing you ask is the liver involved or not? If the liver is not involved, it's very likely to be prehepatic. If the liver is involved, it's either reflecting intrinsic disease in the liver, or it's because the liver is absorbing disease that is being radiated downstream, radiated upstream from the heart. Yeah. Is there anything else that you think was helpful to re-emphasize before we talk about your case, Kashayar?
So this is actually a question I had during the rewatch of the case. During the case, as you were discussing possible locations of congestion, you discussed the possibility that this could be congestion versus infiltration before we got kind of uh, confirm about it being congestion. And one thing you mentioned was that the chronicity of the presentation
Yeah.
was actually in favor of it being congestion rather than infiltration. And I didn't really understand why.
Yeah. Yeah. I mean, I think it's yeah, sort of ask yourself, um, what is fundamentally the difference between congestion and infiltration? And I think to have that conversation, we first must ask ourselves, well, why are they even in the same category? And they're in the same category because they're both microscopic diseases that are hard to notice radiographically. And so to really visualize them, you need to be studying these diseases at the microscopic level. And the fundamental difference between the two is on the microscopic level, congestion is just water taking up space versus infiltration, which assumes that there is not liquid, but solid material taking up space. And so, if you're trying to make an educated guess as to the time course and what time course is more compatible with each of those two categories, especially a long time course, um, by virtue of it being uh, a a process that is often requiring active cellular replication and activity. The majority, I would say, of infiltrative diseases progress at a pace that is faster than congestion. And if you were just to even, I was trying to simplify it even to one word, ask yourself, which is alive and which is dead, right? I mean, just that sort of simple concept of like when you look under the microscope, those processes that are causing infiltration, be it lymphocytes, plasma cells, amyloid protein, lysosomal deposits, they're breathing, you know? In stark contrast, water's just there. And so the rate of congestion is just dependent on the rate of the venous hypertension. And the venous hypertension can be very acute and very fulminant, like in rapidly progressive heart failure. But as we know, there are many versions of congestion that are ultra chronic. So, for example, venous stasis, right? If you have the equivalent of venous stasis happening in the hepatic vein, um, so if you have Budd-Chiari physiology from a congenital malformation or a web, it's chronic, it's going to be there forever. And so when something is infiltrative, you can definitely have a infiltrative process that lasts a lifetime. And all you have to do is just dial down the rate of replication of the disease process that is infiltrating the liver. But by its very nature, water has no replicative activity, and so the rate of water congestion is purely a function of the plumbing issue that's causing it to be down there. So if you're making an educated guess, when somebody has had space occupation in one area for a long time, um, odds are that it's been by something that's not alive or destructive. It's just ballooning in the area.
Okay, thank you. So far we've reflected on the original case, and the case that I want to present today is a case that I saw 3 days before Zachariah presented the
Wow.
original case. So the coincidence was really fun.
Yeah.
And I'm gonna start with the first aliquot. I don't think we're gonna need a whiteboard because the information is relatively short. And this is a story of an 11-year-old boy who presented to us with a history of GI bleeding 3 months ago, who was diagnosed with esophageal varices and is now coming for a follow-up endoscopy.
Hmm.
And I'm gonna stop there for the first
Yeah.
aliquot.
Yeah, so Siva, just to practice, what progress do you think you've made with the information that Kashayar just shared?
He mentioned that the patient has varices, so I'm assuming he has portal hypertension.
Ah, beautiful.
Uh, and he's 11 years old, so I am biased towards congenital hepatic fibrosis.
Amazing. Yeah, I think it's such a powerful thing to say. Like you're seeing the most common way that portal hypertension is diagnosed with esophageal varices. I think the only exception to the idea that esophageal varices may be not reflective of portal hypertension is when somebody just has disease of the small veins that drain the esophagus, and that's the splenic vein. So the only break in that possible leap that we often do is when somebody has isolated splenic vein disease. The most common way we see that in adults is as a result of the splenic vein contacting the pancreas and causing and resulting in thrombosis from pancreatitis or local compression from pancreatic cancer. So I think that's uh, um, that we can likely say 90% portal hypertension. Um, and Pranay, yes. Pranay presented a case also of less common splenic vein diseases, including an AV fistula, which you really should check out. It's a really cool case. So yeah, I think Siva, this case really becomes now a case of portal hypertension with some few exceptions. All right, Kashar, back to you.
So you, as a first year intern, newly minted, you go see the patient. He is completely normal on physical exam. No abdominal tenderness, no hepatosplenomegaly, nothing. No history of bleeding after the original episode. He's just completely fine, which is good. And he has a sonography result from a month ago, which he took for follow-up before coming for his next endoscopy. And it doesn't show anything abnormal. We were expecting portal hypertension, but we don't see anything on the sonography. Everything around the liver looks normal.
Fascinating. Sorry if I missed that. I was reading Kritika's excellent comment in the chat. When you did the repeat scope, there was no varices, or when you sorry, I missed what you said. What the pertinent negative?
Before doing the repeat scope, we
I see.
see that the patient has a sonography with him,
I see.
and that shows everything is normal.
Everything is normal. Okay, super helpful. So Magnus, if you put your thinking hat on, and I think one thing I just emphasize as you do that is how powerful this pertinent negative is. We often underemphasize pertinent negatives because they just slide under the radar, right? But here, this is huge. So I'm curious, what progress do you think you're able to make with this information?
Yeah, so I think when we don't see anything on the liver, it's in my mind it's something similar to like image negative abdominal pain, meaning that we have some sort of molecule or some diffuse problem that's just too small for us to see on an ultrasound. Yeah, so I'd be curious for if there's like anything metabolic going on that somehow leads to portal hypertension or some diffuse anatomical like abnormality that's just not large enough for us to see
Yeah,
on a sonography.
excellent. And if you had to take your finger and point it to the location of the obstruction, and use the liver as your point of reference. So would you point at the liver, downstream, closer to the heart, or upstream, closer to the esophagus? Where do you think your finger is gravitating towards?
And so I think we need to go a little bit upstream from the liver because if we had a like a lesion after the liver,
Yeah.
we would probably, and we had portal hypertension, we would probably see some sort of hepatomegaly, I think.
Yeah. Excellent. Excellent. Yeah, I think I'm right there with you. I would say that I find the most powerful pertinent negative here to be the lack of ascites. Ascites can be absent in cases of portal hypertension for two reasons. The first is it's early, and it's early such that the intraluminal pressure within the portal vein is not high enough that it needs to leak to decompress itself. That hypothesis would be compatible with somebody who has maybe some mild varices, but not somebody who has just bled from varices. So early portal hypertension is plausible because people can present unusually, but I would say this degree of varices and the fact that he bled has that hypothesis a little bit less likely. And that's a reminder that that the presence of ascites often implicates the fact that the hepatic sinusoids are the source of that leak, and that the pressure is building up within the liver at the hepatic sinusoids, and that's where the fluid extravasates out of those cells that have holes in them. And so when you don't see ascites, you have a very, very high likelihood of having a very, very proximal upstream source of portal hypertension. And I think herein lies a really, really important point about Zachariah's case. Because Zachariah's case had no ascites, and yet the disease was in the liver. And I think this is a key thing to understand, which is to really reflect and fine tune our localization within the liver. And within the liver, the localization is divided at the microscopic level between with the point of reference being now the sinusoids. And the sinusoids are essentially the capillaries of the liver. And before the sinusoids is the portal venules, which are carrying fluid from the portal vein to the sinusoids. And then post the sinusoids are the hepatic venules that carry fluid to the hepatic vein. So you're seeing a little bit of a mind trick here where the initial localization of portal hypertension is post-hepatic, intrahepatic, or prehepatic. And then within the hepatic localization, there's a further subdivision into three different categories, which is it sinusoidal, post-sinusoidal, or pre-sinusoidal? And the vast, vast, vast majority of intrahepatic causes of portal hypertension are sinusoidal, with cirrhosis being a localization right there where these nodules form that compress those sinusoids. Sinusoids leak, and you get ascites and portal hypertension. Pre-sinusoidal intrahepatic portal hypertension is the sneakiest category of all because fundamentally it's actually prehepatic, meaning that even though those venules are in the liver, you can just dissect them out, remove them, and they have no actual communication with the liver. So if you're ever going to be confused by a pre-hepatic cause, it's going to be a pre-sinusoidal intrahepatic disease process. Now, if you followed that, your IQ is too high. Take it easy, slow down. So I'll say it one more time. The liver is a massive structure. It's also broken down into three parts, with the point of reference being where nutrient exchange occurs in the sinusoids. The gray zone of localization of portal hypertension is between the macroscopic portal vein or the microscopic portal venules, which coincidentally happen to be in the liver, but functionally they actually have no impact on the liver itself. And a classic example of this phenomenon is schistosomiasis. So what happens in schistosomiasis is those tiny eggs, they actually lodge in the pre-sinusoidal hepatic venules, tiny portal venules, tiny little eggs cause fibrosis there. So the liver And the actual liver parenchyma is almost completely normal case like that. And congenital hepatic fibrosis is a disease of fibrosis of the portal venules, just like schistosomiasis. As we discussed previously, congenital hepatic fibrosis also causes some other things affecting the biliary system and whatnot, and that's how you diagnose it. But ultimately, distinguishing congenital hepatic fibrosis from schistosomiasis is quite difficult. So, Magnus, what would I say? I think, yeah, it's the silence of the ultrasound is powerful, and I think the lack of ascites suggests either early portal hypertension or um, or it's very, very upstream. Where could it be? Anywhere from the portal venules infiltrating the liver to the portal vein itself. And I think the absence of ascites is such a powerful diagnostic tool. Ultimately, you can also try to make a checklist and compare and contrast two features of portal hypertension to help you make progress. And those two features are extravascular features of portal hypertension or intravascular features of portal hypertension. The more and more and more and more upstream you are, the less and less and less you have the ability to have release the pressure outside the vasculature. So if you're in the heart and you have portal hypertension from right-sided heart failure, you have so many opportunities to release the extra pressure outside of the vascular system. You can release it into the liver and make the liver congested, and then you can release that into the peritoneum and cause ascites. So many release valves. Post-hepatic, post-sinusoidal, and sinusoidal all have the opportunity to breathe out that fluid and dump it somewhere else. So there is less and less and less accumulation inside the vessels themselves. When you have either pre-sinusoidal or truly pre-hepatic, there is no room to breathe. This is why these patients present with massive splenomegaly. This is why these patients present with severe GI bleeding. And this is why these patients have not just esophageal varices, but actually a high rate of ectopic varices outside the esophagus, in the rectum, anywhere in the bowel, and even in the peritoneum. They also tend to have macroscopically distorted portal veins, causing portal cavernomas, malformations of these blood vessels, and those things can compress on adjacent structures, like compress on the biliary tree. So one thing that I try to do is to say, what is my cumulative complications that are intravascular versus extravascular? And the more and more and more I see that there is no release valve, that everything is being forced back into the GI lumen or into the spleen, the more and more I worry that the obstruction is actually in the portal vein or the pre-sinusoidal vasculature. So what is an ultrasound really good at? It's really looking at release valves. And when there are no release valves, I think you can be pretty confident that the obstruction is either in the portal vein or the microscopic portal vein within the liver, the pre-sinusoidal liver. And Saket's summary is just perfect, spot on. So that's a lot to digest. I'll send you some visuals afterwards, but let me just stop there to see what questions folks have, and then we can hear your next alquad or any questions you have, Kashayar.
Maybe I can just ask Rabih because I I get the point that like sinusoidal in cirrhosis we have this portal hypertension and the sinusoids leak, but I don't think I got why the venules don't leak or they don't leak as much fluid as is needed to for us to detect ascites. Or I understand that it
Yeah.
gets backed up in the spleen, but why is it that we don't also see ascites when we have pre-hepatic, no,
Pre-sinusoidal.
pre-sinusoidal
Yeah, yeah, yeah,
intrahepatic?
yeah, yeah, yeah. Good job. Yeah, if I were to try to simplify, so I think Lyra shared an excellent episode of the Curious Clinicians, which I highly recommend you listen to. They will probably arm you with such helpful detail that my sort of like this overly simplistic mental model meant to like have a constant working grasp of this concept, losing the details is really what I'm fundamentally sharing with you. So I'm making a link and pasting it in my notes so I check it out again. I listened to it a while ago, maybe a week or so ago. But yeah, I would just kind of share with you is that um, that I think the core issue is that the venules, no matter which ones, hepatic or portal, are not fenestrated and do not leak unless they hemorrhage. The sinusoids, in stark contrast, are designed for exchange of nutrients, of everything. So they're fenestrated. So it therefore is very easy to see why a sinusoidal cause of portal hypertension will cause those sinusoids to bleed. To leak, not bleed. But what truly causes portal hypertension, anything beyond those sinusoids, will radiate that pressure to the sinusoids themselves. And so if you have hepatic venule disease, meaning disease further downstream, the pressure is communicated upstream to the sinusoids, which leak. The portal venules, which are the venules before the sinusoids, where do they radiate their pressure? Every opportunity they have to radiate their pressure is in a non-fenestrated structure. And so the only mechanism by which they can release the pressure is literally bursting. Where do they burst? At the site of highest pressure, where the wall can be overcome by the highest pressure, bleeding. So portal pressure is always going to be released somewhere. And you're helping me crystallize that the message is actually very simple. Is the pressure being released in the hepatic sinusoids in the form of a transitive fluid? Because you don't need to hemorrhage because you're fenestrated. And in those patients, they'll have ascites. You can tap the ascites and study it. Every other person is going to release their pressure in a more sinister way because every other localization has no fenestrations, has no holes. And so where do you release the mechanism? You release it at the site, assuming the wall strength is the same or similar, at the site where the pressure is so high that it overcomes whatever wall strength is fighting back. And that's the pressure builds all the way until you get to the esophagus. Does that help? It helped me certainly help me clarify what I'm trying to say. Does that help you, Agnes?
Yeah, thank you so much. That I get it. It's
Awesome.
yeah.
Awesome. Other questions from anybody else?
I have one question.
Yes.
Re this intrahepatic, pre-sinusoidal, and pre-hepatic are
Yeah.
com presentations are similar,
Yes.
right? Clinically, it's just pathological classification kind of thing. And the
Yeah.
same,
Yeah. Presentations are identical, Siva. Absolutely identical.
okay, same with the post intrahepatic, post-sinusoidal, and post-hepatic.
Yes.
Right. Okay, got it. Thank you.
So you can literally just say uh, sinusoidal, post, or
Hmm.
pre. And sinusoidal is usually obvious because there's pretty significant characteristic liver dysfunction. So cirrhosis, for example, right? The accompanying features of the liver parenchyma allow you to say, hey, I think this is sinusoid. So if you have chronic biliary injury, you have all sorts of things that use the liver is like unhappy. Of course, the liver can be unhappy because there is chronic congestion, but chronic congestion has a relatively unique profile of liver injury that isn't as bad as intrinsic liver disease. High alk phos, high bilirubin, high INR. So you can just really say like, I'm just going to say sinusoids, post-sinusoid or pre-sinusoid. Definitely. And then both those two categories of non-sinusoids, one word can help you make a lot of progress. Macroscopic or microscopic. Because you will see the heart. You will see the hepatic vein. How? Ultrasound, CT, autopsy. You can see it. You cannot see the venules. So I'm going to apply this great leap that you're making to say, okay, there is no ascites, so this has to be pre-sinusoidal. There is no macroscopic evidence on the ultrasound, so this has to be, all the appropriate caveats, has to be pre
Hmm.
uh, sinusoidal, but intrahepatic. So we can take the lack of ascites to say it's before the so if we like this is heart, this is liver, this is esophagus. The lack of ascites is liver and before, but the ultrasound is telling us there's nothing wrong in the portal vein. And with those two things, you can sandwich the disease to say, hey, I think this is intrahepatic, but pre-sinusoidal. Why is it intrahepatic? I don't see anything in the portal vein. Why is it not at the sinusoids and beyond? No ascites. Now, there's caveats to all these things, as is true in medicine, right? The sensitivity of your test, who did it, how advanced in the disease process is. But I would say that I have like 80% confidence that the disease is somewhere there. Well, any questions about any of that? Yeah, I'd say like two from this really fun conversation. I think we're seeing two powerful things, which is release mechanisms. Where is the release mechanism? If you're gonna have a release mechanism, you will choose to release without bleeding, then release with bleeding. And so here there is no release mechanism at all. There is no sinusoidal fenestration. And so like, okay, the sinusoids aren't involved here. Like, okay, this must be before the sinusoids. And if it's before the sinusoids, it's a big, massive vein. There's truly nothing wrong with it than the small veins in the limb. All right, Kashayar, any questions, reflections you have, and then we can see how you cracked your case.
I just want to take a moment and be like, this was so cool. So, one question that I have is, would you repeat the ultrasound?
Definitely. It's such a high stake. You see how high, thanks to Magnus and Siva's prompting, you see how high stakes it is, right? So I think you, yeah, I think you're hanging such powerful diagnostic information on it that I think, oh my gosh, if we do it again and we see ascites, well, our whole localization is gone. If we do it again and we see that there is a portal venous thrombosis or a cavernoma, yeah, so I think I'll jump in to answer that question. I think it's so crucial that I would definitely want to do it in a place that you have a relationship with, not just trust, but also dialogue. Like you trust but verify everything. But you want to be able to talk to the radiologist to be like, hey, this is what I'm thinking. Let's get as much juice out of this ultrasound as possible.
So, we did repeat the ultrasound. And in this new one, we saw some interesting things. First, the portal vein had normal caliber. There was no evidence of hepato portal hypertension that we could see there, but the liver showed coarse echogenicity with preportal echogenicity and inappropriate size of left and right liver lobe. Two small adjacent cysts in subdiaphragmatic of right liver lobe suggestive for Caroli disease. Preumbilical collateral veins were seen, and bilateral kidneys were enlarged with increased echogenicity with punctate echogenicity foci in medulla of bilateral kidneys. So just to summarize, some echogenicity foci suggestive of cysts in the liver, a splenomegaly, and bilateral kidneys had echogenic foci suggestive of cysts. I think you're muted, or
Sorry.
is it?
all every time. Do you mind sharing with us what the size? There was some mention of the size differences between the respective lobes. Can you remind me of those?
Um, okay, let me. They they just mention an inappropriate size of left and right liver lobe. They don't mention exact measurements.
Hmm.
And the only other measurement is the splenomegaly, which was 148 millimeters.
Awesome, awesome. So maybe we can just do a quick 5-minute breakout room for folks to share their thoughts about this ultrasound. Um, I'm thinking, Kashar, maybe if you have a moment just to type the results in the Academy
I'm
chat.
gonna share it in the group because yeah, it was a
Awesome.
lot.
Perfect. Yeah, it's a lot of information. So just to see how much juice you can get out of it, and then we'll come back and talk about it as a group. Okay, so let me hit the call back, folks. Curious what questions emerged, or if any, um, in your conversations. All right, I'll just start blabbing away and see what things. Oh yeah, Kasha, it looks like Mark is wondering if you have the previous ultrasound report, which I remember was completely normal.
Yeah, unfortunately, I don't have the exact
Yeah,
report, but yeah, basically it was everything looks normal.
yeah. Which is, I think it just emphasizes how subtle these things can be. Yeah, I've been in many situations where even HCC was reported to be normal on an ultrasound that was like within 4 days later repeated. So yeah, I think thank you for directly asking the question, should we repeat the ultrasound? And I think you're seeing, I would just, for clarity's sake, emphasize that these things were there on that previous ultrasound. They were just not, the entities that you're seeing, these cysts don't develop in a short period of time. They've been there since a long, long time. So what are we seeing here? I think we're seeing the first thing is the emphasis on that the portal vein is intact, and that we're seeing clues to localized lesion. So what are we seeing? We're seeing cysts in the liver, and we're seeing cysts outside the liver. And so, what are these cysts specifically? For those of you who are, so there was a smaller group then, part of the reflection session. Um, the relationship between Caroli's disease and Zacharias entity congenital hepatic fibrosis is actually a very interesting one. So strictly speaking, congenital hepatic fibrosis is just isolated congenital hepatic fibrosis. You just have fibrosis around the portal venules, and that causes portal hypertension. Well, how do you know that that fibrosis isn't from schistosomiasis or whatnot? Is patients with portal congenital hepatic fibrosis have these really characteristic bile duct abnormalities. So it's not just a venulopathy, it is a biliary portal venulopathy. And helping us understand it is just simple anatomical proximity, which is that the bile duct cells and the portal veins inside the liver are right next to each other. Very, very adjacent structures. So it's very easy to see how a fibrotic process can easily affect both. What is Caroli's disease? Caroli's disease is an extension of congenital hepatic fibrosis, whereby the biliary abnormalities extend from not just the microscopically small bile duct cells that are right next to the portal venules, but actually the medium caliber bile duct cells that are larger, that are heading towards the major hepatic ducts. So congenital hepatic fibrosis is a microscopic small caliber disease of the portal venules and the adjacent small bile ducts. Caroli's disease is a disease that often includes those two structures being affected, but also includes the medium-sized bile duct cells being diseased, so much so that they actually dilate and sometimes even dilate enough to pool. And so you see these biliary islands in patients with Crowley's disease. And unfortunately, that can lead to some consequences, especially stasis of bile. And whenever there's biliary stasis, bacteria will come. And these patients often have recurrent episodes of cholangitis. It's also true that patients with Crowley's disease have a extrahepatic signature on the spectrum of similar entities like autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease. And so they have pancreatic cysts, kidney cysts, and they have some neurological manifestations as well. So I would say here that what are we seeing? We're seeing medium-sized bile duct cells involved. We're seeing microscopic biliary disease, microscopic portovenual disease, um, all coming together in what likely is a syndromic entity here. The size of the liver is very powerful. So when you have portal venules, they also choke off and starve the liver. And so what can happen is that in very, very late stages, you can get hypertrophy of the caudate lobe and relative shrinkage of the right and left hepatic lobes. Doesn't happen in everybody. And that has to do with the fact that the caudate gets systemic blood supply and systemic drainage more so than the right and left hepatic lobes. So you'll see in patients who have chronic prehepatic portal hypertension, they can get relative caudate hypertrophy because the caudate lobe has this unique sort of blood supply. So that's the juice that I get out of this Aleph Kashayar. I'll hand the mic to you to really curious how you're thinking about it, how you're reflecting about it, and what you're learning from this case.
So I really learned a lot about the case afterwards during the session with Zachariah because at first when we saw the second sonography, this is when we really start to think about congenital hepatic fibrosis and Crowley disease. We don't have the ultimate diagnosis yet. The patient is scheduled for a liver biopsy in 5 days, and hopefully I can get you guys a follow-up if I see the patient. I'm not on that rotation now. But afterwards, while I was reflecting on Zacharias' case, the entire anatomy of the liver and how the post, pre, and intrahepatic framework that we have used similarly in things like how we thought about lungs and hypoxia, how we thought about kidney failure, how we even thought about bladder obstruction during the session that we were discussing together. This framework is really interesting to me and how it can simplify a lot of complexity into a single framework. And yeah, I this was my main thoughts about it, aside from the cool syndromic presentation, which can, as you mentioned, be associated with polycystic kidney disease. And yeah, this was my main thoughts here.
I really appreciate. I mean, I think that for those of you who are more recent to the academy, I would jokingly refer to Kashayar as the philosopher because of his very, very deep and profound questions he would frequently ask me. Honestly, it would catch me off guard a little bit, and I think you're seeing that on display today as a co-teacher in this session. Yeah, I think coincidence in medicine is an ever decreasing phenomenon for me as you realize that you're like, well, how could these two things happen so close together? Is it a coincidence? I think the answer is no. There's so many things that are so intimately related to each other in medicine that you'll spot these coincidences all the time if you're looking for them. And so I'm glad you did. I'm glad you shared that with us. Yeah, I just emphasize that the localization of portal hypertension, I think fundamentally just comes down to finding out where the release valve is. Ideally, your release valve is in the sinusoids and you have ascites. And so you have therefore diagnosed the disease in the sinusoids or after. And if that's not happening, you're dealing with a pre-sinusoidal issue, which you can simply take a glance at the macroscopic portal vein, and if you don't see anything there, you've localized your disease. If you do see anything there, the answer is right there. It's a very, very powerful story of just knowing how to look and where to look. Ultimately, though, it's the first phase, right? As in neurology, we have to localize the lesion, and once we do, we have to study what the causes are. I encourage you, as I've been emphasizing more and more and more, is to be very calculating and strategic about how you get to the problem. Localize first and then study. And so we did that. And then once we localized to the pre-sinusoidal intrahepatic structure, um, you now are looking for things that can clue you as to what happened. And now we know of this entity, Corley's disease, which is associated with congenital hepatic fibrosis, a typically uh, 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 a classic pre-sinusoidal entity, but often lacking any other clues, which requires a biopsy to detect the clue of the bile duct abnormalities of the small bile duct cells. And that's what Zachariah did. Zachariah didn't have any other clues to help him figure out his case. So he did a liver biopsy. He's like, oh, next to these portal venules, which I've confirmed is the location of my disease because I see fibrosis around them, are these bile duct plate abnormalities. Ah, congenital hepatic fibrosis. But if you were lucky enough to see clues elsewhere, you're like, oh, well, look, cysts in the kidney, cysts in the liver. Oh, look, pools of bile. This must be a portal prehepatic, sorry, a pre-sinusoidal intrahepatic portal hypertension and medium bile duct cells disease plus cystic changes. If you put that in Google or ChatGPT, very likely tell you. Corollias are maybe some things I haven't learned yet, but I can see why the radiologist is very concerned about Corollias disease. It lines up with the independent localization exercise that she or he isn't probably privy to. Cool. Well, thanks so much for hanging out, y'all. I know there's a lot of learning left this weekend, so I'm sure I will see some of you later on. Have a great rest of your day. Thank you again, Kashayar. I will hand the mic to you for the final words of wisdom you want to impart on our friends here.
I just want to thank you for an awesome session. I studied, I know, like at least 2, 3 days about different causes of portal hypertension, and you just came in with like whoosh, half an hour. It's all cleared up now.
Yeah.
So yeah, thank you for a great session. Have a good day, everyone.
You know what I'm taking away from you, Kashar, from this session is that those kind words, which quite frankly are just so many years of thinking about the same thing over and over again. So I wish you many more hours of reading in the future about this. I'm also taking away with it the incredible amount of curiosity I see in everybody's faces, like Jillian, Magnus, Saket, Leah, Siva, Simi, and Rahul, uh, are like walking out of the session not like, oh, I get it, which is great. I think most people are like this. And I hope that you stay like that forever. Like, you will never, ever, ever walk out of a session or a case being like everything's crystal clear. That's an illusion of, I think, of learning. I hope you always walk out with skepticism, curiosity. And so I used to strive towards ending a session where everybody's like, huh, I get it. But nah, I don't think that's possible. We'll never fully get it. So keep that curiosity on. And if you feel that, like, that doesn't really, I gotta listen to it again or I gotta read more. Yes, that's the goal of this session. So stay hungry, keep reading. And if you have any clarifying questions that I can help with, feel free to message me. I'd be glad to nerd out with you. All right, guys. See you later.